Now, what we're going to do today is basically to let you understand the concept of guided tissue regeneration. Guided tissue regeneration in the real context of GTR. So that I will introduce you to the single guided tissue regeneration, and then I'll introduce you to the Ogunsalu sandwich regeneration technique, which is a double GTR, although mathematicians have recently told me that it is not double GTR, that it is cubic GTR, and I agree with them that it is cubic. And you will understand very soon why this is so. So, we are going to proceed and show you GTR at its simplest. A lot of you, when your patients come in with gingival recession, you just, with sensitivity, you just slam composite resting there. And I don't unless the patient is not willing to do surgery, unless the patient cannot afford the surgery, then I will probably do that. But my first line of treatment is to bring the gum down. And this is actually possible. Now you can see the gingival recession here. So what you want to do is you want to raise a flap in such a way that the interdental papilla are preserved on both sides. Because you need the interdental papilla for the reattachment of your flap. So you're going to make a flap like so, so you will end up with something like this. Now, you will then slit the periosteum so as to make this flap very flabby, and that is what is being done there. You see, supraperiosteal sharp dissection is used to mobilize the flap. So once you do that supraperiosteal sharp dissection, you are good. You're good to go. And you'll see me do that sharp supraperiosteal sharp dissection tomorrow with a GTR case that we have. Now, you now passively reposition that flap coronally. And you will notice that it is almost covering. You see, the edge of the flap is covering the papilla area. And that is what you want. Now, you now de-epithelialize the papilla. You bleed it because you want it to be raw. You want its raw surface to meet with the raw surface of the flap so that you suture raw surface to raw surface, and when it is healing, they heal together. And that is the glue. That is how it's going to stay there. So it's not going to move up. And you know, you don't need to buy any implant machine or anything to do this procedure. You don't need to buy implants to do it. You just go ahead and do it. Just scalpel blade and so on and so forth. So that you de-epithelialize. Now, you see what they are doing is they are scraping a layer of the papilla, interdental papilla. But I don't do it like that. I bleed it. I puncture it all over. Puncture it all over, puncture it all over, and it works for me. It works for me. Now, after you have de-epithelialized the papilla, the next thing is to trim your GTR membrane. And of course, today, this is optional for simple GTR like this. This is actually optional. Now, Gore Resolute used to sell the membranes in different shapes and different sizes for different teeth. And, you know, you put in your membrane, and in those days, the membrane will come with a suture, and you put a sling there, and you tie to maintain your membrane in position. But again, you know, it takes time. What you're seeing there takes time, huh? And I don't do it like that anymore. It's either I leave it there and use the edges of the flap, you know. You can tuck it in there, and then you close. Or you can tack it, and I'm going to teach everybody how to auto-tack. Next. And that is your closure. You can see your closure there. Now you compare this with the first slide. Previous. You see that? Now, the last one I did was a very, very curious postgraduate. Well, actually, he finished his postgraduate in engineering. He's working. He had 3, 4, 5, 6 on the right and left side with gingival recession. And I tell you, you know, I gave it back to him exactly the way God gave it to him. I was very, very happy. You know, it's the best I ever did. Considering the fact that it was just about 4 teeth together on both sides. And I didn't use membrane. So that for these, the most important thing is your flap design, the deepithelialization of the flap, of the interdental papilla, and your suturing. And if you have membrane to use, you can use it, but I don't think it is mandatory in this procedure. And I'll show you GTR where membranes are mandatory. Now, quickly, a question?
To de-epithelialize the papilla, you just scrape the periosteal.
No, just the skin, the gum, the surface of the gum.
The part that is fixed, not part of the flap, the other part that is fixed to the neighboring teeth.
Yeah.
Oh, okay.
This part, look. This part that you didn't cut off. You know that normally, most people will cut their flap like this, huh?
Yeah.
And raise everything.
Yeah.
But you are leaving this, huh?
Yeah.
Because you want this to glue to this, and this to glue to that.
Yeah.
It will not glue unless you make this raw.
Yeah. I got you.
And that is the magic to the surgery. You know? And Emerson, insurance pay for it here. They'll pay, I think, $25,000 or $30,000 for it. And then if you use membrane, if I'm going to use membrane, what I do is I sell the membrane separately to the patient. Huh? Tell the patient you buy the membrane and then we use it. But you don't need membrane for this. Now, the other things that I will show you, you need membrane for this. For them, you need bone graft for them. Yeah, next. Next. Now, I just want to show you this character here. This is a bottle of BioOS. And you can see how big the bottle is. And I don't know why they make this bottle like this. And they just give you this tiny little piece of bone grafting material. And this is about $200 US, you know. And next. Of course, they also have this bone grafting material as cortical and as cancellous. And they have them in different sizes. They have a small particle, you see it's S, and then you have large particles. All right? Next. BioGuide has two surfaces. The smooth surface, which is marked up. And the reason is they want that smooth surface to face the soft tissue. Next. And then you see the rough surface, which faces the bone. Okay? Next. Now, these pins here are the autotac pins, which you are going to learn how to use before you leave. And, you know, the reason is when you start GTR, you want your cases to be successful. And, you know, yes, you can pray to God for success, but again, you have to help yourself for success. You know, if you put something there and you don't stabilize it, how do you want it to stay? Huh? So these are the things. So that the company that sells the autotac pin is BioHorizon. BioHorizon. And they sell 5 of these pins in a bottle. And the 5 cost $81 US. But they sell it to me for like $50 US. And I'm telling all of you here today, you know, I like teaching, huh? And I don't get involved in sales except for the fact that I like to get things cheaply for my delegates. And anything you want to buy, talk to me about it, I'll get it cheap for you. Even you want to buy an ADEC chair, I'll get it cheap for you. You can't get it the way you're going to get it. You understand what I'm saying to you? And I don't get commission or anything. I'm not interested in it. But what is the use of me teaching you something and you can't buy it to use, you know? So I make arrangements and I get good prices for people who come on my course. So that I could easily get you these for almost half the price. Next. Now those pins, you arrange them in this carousel. You see that? That's a pin there. That's an empty hole, empty hole. And this whole carousel can take about 50 pins. All right? But I don't put more than I need for a surgery there at a time, so that I can wash and sterilize. And before I go further, those pins are stainless steel pins. And OsteoHealth, a few years ago, started to manufacture the resorbable pins, the pins that we resorb. And of course, I bought them, I used them, and of course, I knew that they were not going to last, and they were going to discontinue it. You see, it was difficult to go into bone. It was difficult to go into bone, and they had to stop manufacturing it. Okay? Now, you will notice that there is a knob here. And that knob goes into a hole in the autotac gun, which I will show you. Next. Now, this is I call this the gun, you know. It has a trigger here. So this nose here, you use it to depress the nozzle, and then you now pick the pin, and then you now press the trigger, and it tacks the membrane into the bone. And for people with shaky hands, this is it. You have this rake with an handle to hold your membrane against the bone, and then you now go through this hole with this mouth here, you go through that hole, and then before you press your trigger. But I don't use this anymore. So if you want to buy my rake, I'll sell it to you, but I don't know what it values. So what I do is I keep it in the kit just to use it to teach my delegates. Next. Now, one of the important things in guided tissue regeneration is to be able to plan your patient and to be able to decide where you are going to take bone graft from. Look at this patient. This patient has bilateral bilobulated torus mandibularis. Bilateral bilobulated torus mandibularis. And if you scrape all these bone here, this can do maxillary sinus lift for right and left. And in the study by Ogunsalu in 1990-1991 in Jamaica, 1 out of every 16 patients has torus mandibularis or torus palatinus. More common in the female, and there is a hereditary pattern. I discovered a hereditary pattern. When the mother has it, the daughter usually has it almost exactly the same way. That was the first research I did when I came to Jamaica. I did that research in 1990 because when my first day in the clinic where I was working, I saw one case of torus, and I was very excited because Dr. Chukwu will tell you that it's a very rare condition in Nigeria. In fact, in Nigeria, when I was in dental school, when a patient has torus, they call the whole school to come and look at it. And I was excited that, wow, my first day in Jamaica, I see oral tori. And then the following day, I saw 2. And I said, what is this? And then the next day, I saw another 1 or 2. So I opened a book, a logbook. I started recording there. And every day, I had a case. And I began to observe the pattern. And this led to a very classical publication, which was published in the West Indian Dental Journal. And that publication has now been translated into Spanish, and it's well distributed in the Spanish literature and the English literature also. And this led to another research on oral tori in Trinidad. Of course, my study showed that this swelling does not occur until after the age of 14. But the study in Trinidad, they claimed that they saw oral tori in a patient 6 years old. And while I was in Trinidad for 7 years, I have been looking and looking. In fact, the oral tori in Trinidad is far, 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 far more less than the oral tori incidence in Jamaica. Now, so this is oral tori, and we should stop taking them out to fit dentures. We should, huh? I think it's a sin. It is extra bone. That's extra bone, spare tires. So you can use a bone scraper to scrape and use it for your periodontal pocket, peri-implant, and also for any bone grafting that you may want to use. And the best way is to use a bone scraper. And that was what we planned to use for this patient. Next. Unfortunately, of course, you see my bone scraper there. Unfortunately, the few days before the surgery, the son of this patient, who happens to, the son is now a dentist. Huh? He used to be my student in Trinidad. He's now a dentist. So he said to me, he said, you know, my dad is not too well, and so on and so forth, and he's very shaky. So I decided to reduce the trauma, because we're doing like almost a full mouth gum surgery for him. We were doing 3-quadrant, 3-quadrant procedure. So I decided that I'm going to use xenograft, okay? So that I'm just showing off with what the patient has, the wealth of autogenous bone graft that the patient has. But I didn't use it. And it's not every time that you have something that you can use it. So because of his health, I decided that I'm going to reduce the trauma and the surgical site. Of course, that is giving him LA next. And when we raise the flap, look at this. See that? That's furcation involvement there. And then you see granulation tissue there. You see the granulation tissue there. The most important thing in a surgery like this is you want to remove all this granulation tissue. And they are soft, but they are very tricky. Sometimes you think you have removed it, but it has crawled somewhere and it's still attached there. So you scrape, you clean, and next. And you can see I'm beginning to have a clean interdental area there. And you can see the bony defects. Next. And of course, I find out that people do not know how to use bone grafting material. They waste it. You have to dispense it bit by bit and condense. You pack it. You condense into the space until you're not able to put in anymore. That is the way you do it. And you may think your amalgam plugger or condenser is no longer useful, but you can sterilize them and use them for this purpose, and that's what I'm doing there. And again, the amalgam carrier can also be used to carry the bone and put it into the interdental area. Okay? So, and these are things that I am teaching you that I have not seen in the literature. I've not seen people describe it in the literature. But these are things that I have been doing, and it has been helping me, and it has been helping my patients. Next. Now, look at this. This is really cute. If I ask any of you, you're going to say to me, this is gum tissue. But this is not gum tissue. This is a membrane soaked in blood. When BioGuide or cytoplast is soaked in blood, that is how it looks. And then what I was doing here, I was testing the area where I'm going to put the pin. Okay? Next. And then you see me going with the gun into there to depress the nose so that I can pick up one of the pins. Next. And then look at that. Isn't that cute? Look at my membrane wrapped around, Dr. Emerson, wrapped around, covering the pin, covering the bone graft. And look at the pin, 1, 2, 3, 4, right? Or three pins. And let me tell you, sometimes I just use 2 pins, huh? Sometimes I use 3, sometimes I use 4. Now, I'm going to ask you to pick up this lecture because you are not seeing the pictures there in your book. Because I added this morning, huh? So you'll pick up this lecture from my son, don't worry. Okay? Now, next. Now, this is the most interesting part. Look at my closure. Look at the excess tissue that I have there. You see the excess tissue? Like, the reason for this excess tissue is that when you are waiting, during the waiting time for the healing, there is retraction of the wound, and also there is some downward apical movement of the flap. So by the time healing is completed, the margin of this flap falls back exactly where it is supposed to be. And this is the management of the gingival recession and bone loss in patients with periodontal pathologic pockets. Next. Yep. Next. Same thing. Next. And basically, that's the end of this presentation. So we go straight to GTR sandwich. GTR sandwich. The lingual nerve is not running anywhere here. You remember that the lingual nerve goes into the tongue opposite the third molar region. Do you understand what I'm saying to you? So you scrape anything in this region, you're not damaging any nerve. Now, you can see this recession here. Okay? Recession relating to natural tooth and recession relating to the first slide. Recession the first slide, Taiwo. Second, recession relating to natural teeth and recession relating to implant. Next, when you raise your flap, that's what you get. You see the recession and the bone loss properly. This is relating to natural teeth, 1, 2, and this is relating to implant. This case was done on a patient who used to live in the US and travel back and forth, and I think something went on along the line. I think the job that this dentist did was very good, huh? But something just went on along the line, and she started losing bone. Next. Next. Then you clean out, you put bone graft, and look at my tack. 1, 2, 3. Look at how I distribute my tack. It's not as if I'm putting it in 4 corners, like 1, 2, 3, 4. You understand me? You tack it reasonably, because these pins are expensive, huh? So the minimum, the better. The minimum that will hold the membrane, the better. Next. And you close. And that is GTR. Next. And look at my suturing. Look at the excess gum tissue. You cannot suture and the area is tense. If you do that, then you're going to lose your bone graft, you're going to lose everything. You'll have wasted your time. Next. And look, that is the sandwich. That is Dr. Mark Zand. This is the sandwich. This is the bone graft inside 2 membrane. Next, I'll show you how we do this eventually. Now, look at that. That's for the anterior region. Next. And also you can use the sandwich to cover the window for sinus lift. And a lot of people do the sinus lift procedure and they think that bone is going to heal over the window. It doesn't. Huh? So you can use the sandwich to cover your window. Next. 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 Right. Now, what I did here is after exposing the anterior region and seeing the bone loss and the defect, now this is my sandwich. You see how the sandwich looks like gum tissue when it's soaked in blood, huh? And what I did was I used it to cover 1, 2 teeth. But it was not long enough to cover this. So I had to put bone here with little membrane. Okay? Next. That's what you have there. Next. And then for the for the maxillary sinus lift window, what I did was I covered the window with a membrane. And then I sprinkled bone on the window. The reason is I didn't have enough membrane. I should have used the sandwich technique there. But you see, the only way you can do that is either sandwich or do it this technique. And this technique has never been reported in literature. And I didn't even bother to write it because I have a lot of other things to write up. Next. Next. And that is the bone graft that I put on top of the membrane. And because the bone graft is sitting on the membrane, which has been tacked over the window and cannot go into the sinus, it is going to heal to form a nice cortical plate there. And how did I know this? Not by 3D imaging or by clinical follow-up of the patient. Before, she had an opening there through the gum. And we followed her up continuously and everything healed nicely. Next. And look at how I suture. I always like to suture this, either the mesial or distal end of the flap last. The reason is I like to steal tissue from here, from this end. And it is very easy to steal tissue from here. You pull forward, and you see that's what I'm doing here. And when I have sutured here, then you now put one stitch here and there, and only one stitch will close the whole of this. If you want to put 2, 3 there, no problem. But the first one must be in the midpoint. Next. And look at my closure again. Next. And that is the AutoTac kit again. AutoTac kit. Next. Previous. Now, you can see the nose of the gun. And then you see this part of the gun, you want to depress it so that, and you depress it by pushing it in here. And you now pick up one of these pins. And it is not power, it is not energy. And you will find out on Thursday that, it is technique. And usually, I'm not intimidating the lady here. The ladies usually find it very difficult to do. But at the end of the day, they do it and they are happy. Next. Look at another recession here. Right? Next. Next. Now, I want to show you how to do the sandwich unit. Remember, BioGuide has a rough surface. Next. And it has a smooth surface. Next. So you create a pillowcase. You create a pillowcase. Max, are you looking at it on your computer? Yeah. You create a pillowcase exactly like this by suturing 2 membranes together on 3 sides with resorbable suture. And then you pack bone graft into the pillowcase. And then use the same resorbable suture to suture the 4th surface. So you end up with a closed sandwich. And the best suture material to use is a Vicryl. All right? The Vicryl. Next. Now, you can put anything in the sandwich. You can put autogenous bone graft. You can put xenograft. You can put anything. Once it's a bone substitute, you can put a mixture. Next. Now, look at another way that I do it. Instead of tacking the sandwich, when I'm suturing, I leave slings on two ends so that that sling can be tied around the neck of a tooth so as to stabilize it there. And if I tell you that this is not gum tissue, you will tell me I'm lying. It looks like gum tissue, right? Yeah, it's nice. But it is sandwich. It's a GTR bone regeneration unit. Next. And when you close, that is what you get. Next. 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 Right. The radiological assessment of patient for implant these days is going far too overstretched. Dr. Amin, do you agree with me? Max, do you agree with me? Far too overstretched. And you will notice the case I did yesterday. At the Panorex, I saw that the patient had bone height. Patient had bone height. Now, we're talking of common sense now. The anatomy of the mandible in that region is that irrespective of any knife edge, under that knife edge is going to be broad. And your bimanual palpation will show the same thing. A bimanual palpation will show the same thing. What your radiological assessment in that case will tell you is that at so level, right, transverse level or cross section, you have a very thin bone, maybe 1 millimeter, 2 millimeter, and so on and so forth. It will probably tell you the level where you are going to cut off the knife edge and then begin to place your implant. Or it will tell you look for another site. But which site are you going to look for there? It's just 1, 2 that you want to place there. So basically, what I am trying to tell you is that at the same time where you are using advanced imaging for radiological assessment, it is very important to use your clinical judgment and your common sense with it. And because it says 3-dimensional imaging does not mean you should go wild and just be basing things on radiology without any clinical correlation. The best radiological assessment is radiological assessment with clinical correlation. That is my message to you before I begin this lecture. And like I will tell my students, next, in Trinidad, that you can use all the following modalities: intraoral, the conventional, intraoral digital, occlusal, panoramic, and computerized tomography. You can even use extraoral radiography for certain purpose. Now, I want to show you I want to show you how stingy I could be. Okay? Every year I set exam questions. And I will ask in the exam question, explain the role of radiology in dental implant therapy. Explain is different from discourse. Discourse is different from describe. So if I say explain, it's like a short note. If I say describe, you describe, and if I say discourse, you discourse. But when I ask the question, I want the student to do it in this way. I want them from the word go. The question is going to be marked out of 10. It's going to be marked out of 10. You mention pre-operative, intra-operative, and post-operative. And each carries 3, 3, 3. So 9, and then you get an extra mark if you do other good things that make me happy. So you could get 10 over 10. Of course, I give students 10 over 10. Right? What I'm trying to say to you is that it is very important for you to divide your role of radiology in implant into 3. Pre-operative, intra-operative, and post-operative. Now, pre-operative, previous. Pre-operative, what you want to do is you want to assess the quantity of the bone. You can't find anything if you don't know what you're looking for. So you're looking for the quantity of the bone, and you're also looking for the quality of the bone. And the quality of the bone is such that you can find out whether it is type 1, type 2, type 3, type 4. Next. Now, for periapical radiography, it is important for you to know that the periapical radiography, previous. Periapical radiography is for single teeth situation, and its application is limited. But the advantage of it is that it gives you a precise resolution. For occlusal radiography, it is single site, it is detailed, it gives buccolingual dimension, and the disadvantage or the limitation is that there is distortion in the maxilla. Next. For panoramic, it is for multiple sites, but the limitation is that you have less resolution, you have magnification, and you have frequent positioning errors. And this is a typical panoramic radiograph. And then for tomographic cuts are precise imaging, and it gives you detailed view of the anatomical site with little superimposition of other areas that you are not interested in. However, the equipment is costly and probably unavailable these days for just the conventional tomography. Actually, nobody does it anymore because of the computerized tomography, and you don't need to know anything about it. And then CT scan, computerized tomography. You can do multiple sites. You have precise estimation. Of course, the cost is the cost of software for these programs. And one of the things that you want to appreciate in computerized tomography is that you have automatic calculation of the bone. Automatic calculation of the bone. Now, look at this. These are radiographs that have been utilized in publications, in implant journals. And you can see that these radiographs are of bad quality. So that when you have your periapical or your panorex, it has to be of good quality. And one of the things that you want to appreciate is that the radiograph is not just for your own use for that patient. It could become a tool for medical legal experts in future. And you don't want people to criticize your imaging and so on and so forth. So that if you send your panorex somewhere to be done and it's not of good quality, don't be scared. Ask. Now, with regards to intraoperative radiography, your intraoperative radiography can begin immediately after you make your incision. You can decide to check something that you feel that you want to check. You can do it after you have placed your pilot drill. You can do it with your trial implant, and you can do it after you have placed your implant. Next. Of course, implantology is supposed to be a multidisciplinary approach with oral surgeon, radiologist, periodontologist, prosthodontist, hygienist, lab technician, patient, and so on and so forth. But I'll say to you that my career so far, it has been a teamwork between myself as an oral surgeon, as a general practitioner, as a radiologist, which I am, a medical doctor, which I am, and with my lab. You know, of course, my patient being involved. Next. Now, let us look at periapical radiograph. If you look at this radiograph, you can say to anybody that this bone is a D4 bone, or maybe D3. Next. Now when you look at this one, you can say, well, looking at a D2 bone. Now, one of the things that you want to also appreciate is that radiographs could be misleading unless you know how to redirect your thoughts. Radiographs could be misleading. Now, you will see yesterday the patient for impression taking is Taylor. The panorex showed that the implant is just exactly close to the root of the incisor. But clinically, that is not the situation. And I remember I got a call from Bahamas some time ago, a few years ago. And one of my delegates called me and said to me, you know, so and so is giving me problem. One of my patients went to him and he's telling my patient that the implant I placed is impinging on the root of the patient's tooth. So of course I had to sort out that situation. Call this person and say, you know, you have to do a panorex, you have to do this, you have to do periapical, you have to check the mouth, and of course there was nothing impinging. Nothing was impinging. And maybe sometimes, to be sure, you may need a 3D to confirm the situation. Next. And of course, radiographs can be distorted, all right? And there's a apical distortion there. Next. And then, you know, you can have imaging modalities, CT scan that can be reconstructed to actually show you the position of the mental nerve, the position of the inferior dental canal, and how far they are to the apex of the implant that you are going to be placing. So as the inferior, those are the areas of importance for you in radiological assessment. How far is the implant going to be to the inferior alveolar canal? How far is it from the mental foramen? How far is the implant going to be from the maxillary sinus? How far is it going to be from the nasal cavity, so that you can decide whether you are going to do a subnasal augmentation or not. Next. And then that is your anterior loop there. That is the mental nerve and the inferior dental nerve. Now, since this lecture was made for presentation, there has been different software and digital modalities for assessment of dental implant patients. Next. Now, this is panoramic, and you have an MCQ question that will detail to you what is the role of panoramic radiograph in the Caribbean. And these are standards that we have set, that panoramic radiography is mandatory in any implant patient that you do in your practice. And the reason is, the panoramic radiograph will not only show you the anatomy of the area that you are going to be placing implant, but it is going to show you distant anatomy and surrounding anatomy for you to be able to appreciate if there is any associated pathology or distant pathology, and so on and so forth. Now, most time the periapical radiograph will show you the site up to about the inferior dental canal, but it will not show you anything further down, so that the panoramic radiograph will sort this out for you. Next. Of course, we have a lot of panoramic errors. Now, the panoramic radiograph could be blurred, out of focus for many reasons, and these are the common errors that you can have. It could be too far forward. The patient may be too far forward, and this could lead to an error. The patient could be too far back. The chin could be too high in the machine. The chin could be too low in the machine. The head could be rotated. The head could be tilted. And, you know, for those of you who do panoramic radiography, this is a tilted head, and this is a rotated head. A rotated head is different from a tilted head. So too far forward versus too far backwards. Now, when the patient is too far forward, this is what happens. The anterior teeth are elongated and narrow. And when the patient is too far backwards, what happens is that the implants become shorter and fatter, or the teeth becomes shorter and fatter. When the chin is high versus chin is low, now you can see when the chin is too low, you have an exaggerated curve of Spee, and the radiograph is going to be too bold, and you're going to have distorted image of the teeth and the implants. When the head is rotated or tilted, now when it's rotated or tilted, what happens is that one side, the side to which is rotated to or tilted to, is going to be fatter. Everything here is bigger than everything here. Next. 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 And that's a panoramic X-ray machine, and something that everybody should actually have in his office. And next. 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 This is tomographic cuts, and I'm trying to move away from it. Right, computerized tomography. Now, computerized tomography, you know, you get different sections. So you can have a transverse cut, you can have a sagittal cut, and you can have a coronal cut. Next. And basically what it's going to show is going to show you and give you information about the bone height and bone width along a span. Next. Next. So basically, one of the things that you want to appreciate in dental radiography is that what are the roles, or what do you want to find out from each of the three? In pre-operative, apart from the fact that you want to appreciate the quality and the quantity of the bone, you want to also appreciate the height of the implant that you are going to use, and also the diameter of the implant that you are going to use eventually. And with regards to the intraoperative radiographing technique for implant, you want to find out if there is any exaggerated angulation of your implant. If your implant is being synced at a level that is too deep for what you have planned, so that you can retrace your step. And there are very many ways to retrace your step in implant procedures. Now, for example, I find it that if I have an exaggerated distal angulation, and I see this on a pilot drill, after the pilot drill has been utilized, then it's just a matter of going back in with a final drill and do a little more mesial drilling, and that will correct it. So that brings us to, and of course, the role of post-operative is very important. And let me tell you one of the reasons why I do post-operative. You will notice that I had my pre-operative panorex, and I had my, I did my procedure without any intraoperative radiograph yesterday. But immediately I finished, I took a radiograph. And that radiograph is a documentation that I have placed an implant in the patient's mouth. It's a documentation of the level that I have placed the implant. And it's a documentation of many things. And my message to you from this lecture is that you must divide your radiography into three: pre, intra, and post. And the truth is, even me in my notes, sometimes I don't divide them like that, and you really have to. Once the patient's, this is a lecture on bone physiology and anatomy. Once the patient's expectation has been determined, the critical element of importance is the quality and quantity of the available bone in the proposed implant site. Bone quality, type, and density is not limited to the specific anatomic region. For example, you can type 3 or type 4 bone may be found in the posterior mandible. And you know that in the posterior mandible, you'll probably find a D2 bone there. Now, let us look at the classification of bone quality and density. I'll give the PowerPoint to you soon. Now, type 1 bone is dense, compact bone, and the tensile strength can be compared to oak wood or maple wood. And that is the deepest, the hardest type of bone you're going to drill into. And you find this kind of bone in the anterior mandible. Type 2 bone is porous, compact, and you can compare it with drilling into spruce wood or white pine. And type 3 bone is coarse trabecular. You can compare it with drilling into balsa wood. And type 4 bone is fine trabecular, the softest bone you can drill into, and you can compare it as to drilling into a styrofoam. That means you can actually drill a type 4 bone with a lady's sharp finger. Now, you may find that the classification of bone that I have referred to as type 1, type 2, type 3, type 4 can also be referred to as D1, D2, D3, D4. And the reference is the same, and the terminology is just, different. Let us look at type 1 bone, and I want you to listen to this because of its implication to your implant practice. Type 1 bone is composed mostly of compact cortical bone. It has minimal trabecular space, making this the densest type of bone. The implication of this is that when you sink in an implant into a type 1 bone, the initial bone to implant interface is approximately 80% with threaded implant. In other words, you already have like 80% integration. So that the implication of that is that a type 1 bone, the healing will be completed in 3 to 4 months. And you can safely load this implant in 3 to 4 months. And this is the area, the shaded area is the area where you find the type 1 bone. Now, type 2 bone, this type of bone generally displays good thickness of cortical bone in superior and inferior border with more trabecular quality bone in the center of the mandible. Now, with this kind of bone type, progressive bone loading should be considered, particularly because the initial bone to implant interface is approximately 70% with threaded bone, and approximately 4 to 5 months is needed before you load these implants. And then the type 2 bone is shaded here, and you will notice this is found mostly between the mental foramen and the retromolar region. Next, type 3 bone, this is considered to be of less crestal cortical bone than type 1 and type 2, and the remaining bone is quite trabecular, and progressive loading should be considered. And the initial bone to implant interface after completion of your implant placement is only 50%, and as such the healing time is 4 to 6 months. So that this kind of bone, you have to tell your patient that, you know, I'm not going to be able to load for you until 6 months time. And this is where you find your type 3 bone, and in that shaded area. Next. Now, type 4 bone is very interesting. Type 4 bone displays minimal crestal cortical bone thickness, with the majority of the available bone being very trabecular. Generally, more implants are recommended to support restoration in this area than in the posterior mandible. Now, what I am saying is that type 4 bone is of poor quality, and this is an area where you want to put one implant for each tooth, and not a fixed bridge with 2 implants for 4 or 5 unit bridge. It's not going to work. And there has been a lot of problems with this, in that, you know, a patient will go to Dr. A, and Dr. A will say, I'm going to put 2 implants there, and it's going to be 5 unit bridge. And then the patient comes to Dr. B, and Dr. B says, no, I'm not going to do it like that. It's going to be 4 implants or 5 implants, and so on and so, and there's a problem. But you will realize that it is poor quality bone. And this is the bone that has the highest failure rate than all the others. And again, when you are talking about implant therapy to your patient, and you're talking about failure and success rate, you must talk to them in the context of bone type. And you must tell them, you know, I'm doing your implant, it's in the upper posterior region, the bone quality is poor, right? And this is the site where we have the poorest bone quality and the highest failure rate. And really, there is nothing that I can change, because already we are placing implants in an area that has a very high failure rate, except for the fact that I'm going to do everything to make this procedure a success, and everything to make sure that this implant does not fail. And of course, what you are doing right away is you are sharing responsibility with your patients. Now, the implication of this is that the initial bone to implant interface is only approximately 25% with threaded implants. Approximately the healing time is about 8 months. Additionally, for fixed restoration, avoid cantilever and consider a minimum of 1 implant for each tooth being placed. And again, you know, brings us to cantilever. It is an acceptable therapy, restorative option in implant therapy. Next, and this is where you find the D4 bone in the posterior maxilla. Next. Now, I'm going to take you into something that is very important, and it is the concept of available bone. Bone is in the proposed site of implant, needs to be evaluated in 3 dimensions. And a lot of time, we evaluate this in 2 dimensions. Now, the 3 dimensions of available bone as they relate to selection of implant is as follows. Now, you have to look at the height. The height of the bone determines the maximum length of an implant that you can place in there without impinging on the maxillary sinus, the nasal cavity, or the inferior dental canal. The width determines the maximum diameter of implant that can be placed in that site. The maximum diameter. And the length determines both the maximum diameter and the number of implants that can be placed in that site. So the length is both maximum diameter of the implant and the maximum number. Now let us look at this. This is the height of the space that you are placing the implant. This is the width, and this is the length. Next. And you can see here, again, you have an edentulous site which is 14 millimeter long, right? That's the length, huh? And then, if you are going to place implants there, so you put in 2 implants, you are just correct in that if your implant is, say, 3 millimeter wide, so, and you are having a spacing of 2 millimeter each, so you have 2 millimeter plus 3 millimeter, that is 5, and then another 2 millimeter, that is 7, and then another 3 millimeter, that is 10, and then another 2 millimeter, that is 12. And in this area, you can only afford to place 2 implants there. You have space just enough for 2 implants. Next. Now, let us look at stress distribution. Stress distribution is very important, and you have to always reflect on what happened to you and your patient. All of a sudden, I realize that every time I do immediate implant, after loading, that's in the maxilla, after loading, I'm going to say just about 30%, will fail. And that is very, very worrying. I mean, the fact that you have 70% that has not failed does not mean you shouldn't investigate what you are doing. And my technique for immediate implant in the molar region, in the maxilla, is that I always target placing it in the palatal socket. Because when you do the extraction, that palatal socket is usually the one that is really, really intact. Right? And you just give it a little angulation to the buccal, and you're good for restoration. And because of these failures, I decided to consider the fact that we are doing something wrong. At least 2 implants should be placed there. And I've started to do that. And of course, there are implant companies that are now marketing wide diameter implant, so that it goes into, but there are problems. And the problems are these. The stress distribution for molar teeth is such that the septation that God kept there is mandatory. It is mandatory. And believe it, there is mathematics to it. And I have literatures to that. And also, in the mandible, for you to place an implant, a wide diameter implant, you will have to be drilling out the patient's normal bone. And sometimes this drilling in the mandible could go apically and even damage the inferior dental canal. And the best option whatever anybody says is to use 2 standard diameter implants at least. And that is what I'm doing now. And a lot of time, the patients cannot afford the second implant. I give it to them free, but I make sure I don't give them any discount on the first one. Give it to them free, and it's up to me to use both for my restoration, which I do. I use both, or use one and leave one, but I use both. Next. So that is it basically. Conscious sedation in oral implantology. Patients with dental phobia who wish to obtain dental implant therapy have the right to request for conscious sedation during such therapy. As such, the clinician should have the ability to provide effective, safe conscious sedation in dental office environment. Let us look at the chronological development of dental conscious sedation. 1940, you had relative analgesia with 20% oxygen and 80% nitrous oxide. That is called relative analgesia. And that is from when you had relative analgesia. In 1945, you had the Jorgensen technique, which I don't know so much about. And then in 1996, you have Berital. 1960, you have Berital. And then in 1966, you had diazepam, IV diazepam, very common. And then in 1970, you had IV diazepam also. And then in 1983, IV midazolam became very common, which is called Hypnova. And in 1988, IV flumazenil became very common. And then in 1990, IV propofol became common. Now, let me enlighten you further that a lot of modalities exist. And in fact, my favorite modality is not here. My favorite modality is IV diazepam with IM or IV petidine. However, petidine is under dangerous drug, and you have to have special permit to store it in your office. And in fact, for me to use IV petidine, I have to go sign off in the hospital, and there'll be 2 nurses, and this and that, and you get it. So, but when I'm in the hospital environment, I do IV petidine and IV diazepam a lot. Before we change the slide, midazolam is very reliable, and it will give your patient the desired conscious sedation. And in fact, in children, it can be used intranasally because the mucosa is very thin and the venous plexus absorbs this. So it's like giving them IV. So that, very troublesome children just drop. But the problem is the titration, the concentration. However, the good news is there are solutions or sprays now for that purpose, but I've never used it. And I will encourage you to search the literature and see what you can get there, and maybe you can educate me further on that. Benzodiazepine-based technique is what we're going to talk about next. Diazepam, which is also called Valium, was first used to provide dental sedation by Davidia in France in 1966. It rapidly became the most common used IV sedation agent for dental procedures. A single titrated dose of 10 to 20 milligrams produces approximately 30 minutes of good quality sedation without loss of consciousness. And that is what you want. You know, patient is well sedated, patient is tired, the patient is not interested in giving you any problem. You can talk to them whenever they want to talk, when you want to talk to them. They listen to you. Sometimes they sleep off and you talk to them and they talk back to you. Now, let us look at the disadvantages of diazepam. It has a long half-life and an active metabolite, which means that recovery may not be complete for up to 72 hours. Thrombophlebitis is a problem. An IV injection causes tissue irritation because of the propylene glycol used as a vehicle. Next. Now what I mean as a vehicle is the solution to deliver the medication. For poorly defined reasons, many dentists combine diazepam sedation with opioid drug. That is what I just said to you. All right? Let us look at midazolam. Despite its similarity to diazepam as regards to properties, it has the following difference. It's a non-irritant solution, a much stronger half-life, no clinically significant active metabolite, increased potency, and up to 3 times that of diazepam. It may not always be the ideal IV drug for dental sedation because of its long period of action when compared to its use for short duration procedure such as tooth extraction. It can be used in combination with opioid such as pentoxazocaine or with ketamine. And again, I like to do things the way it's supposed to be done so that I don't get into trouble. And basically, in my office on Market Street, I used to bring in an anesthetist every Saturday. We sedate patient. He does ketamine and midazolam, and and of course, one of the problem is it's an upstairs. You don't have emergency protocol setting, so in case something happens to the patient, and his colleagues, and this is how life is, right? His colleagues that I used to call to do GA for me were not very happy that all those GA cases have now been converted to sedation inside my office. And they were just waiting for something bad to happen. And really, something bad almost happened one day. I mean, a little 6-year-old boy, simple tooth extraction, was sedated, was actually mentally retarded or challenged, right? And we had problems, but fortunately, I could resuscitate the patient. And, I decided that, no more IV sedation in my office. You understand what I'm saying? Because when these bad things happen, let's say the patient died, you're going to hear, patient died in that dentist man office, huh? They're not going to mention anesthetist's name, huh? Serious. And the only person who can pursue the anesthetist is me, just to clear my name, but the public does not know that. So that really, I am saying to you now that you must not do IV sedation unless, one, you have a trained anesthetist, preferably a consultant anesthetist. Two, you have to have a trained nurse with you. And three, you must have all the resuscitative equipment and pulse oximeter to monitor the patient. And it is with all these three criteria that you can do IV sedation in your office. And basically, we should understand that people have gone and trained as anesthetists and so on and so forth, and this is what their job is, so maybe we should leave their job to them and focus on our patient care. But sometimes it is really not possible, and you really have to sedate your patient on your own. And that is why I am stuck to oral sedation. It works for me, it works for the patient, and we've not had any problem. Flumazenil, this is a specific benzodiazepine antagonist which reverses most of the agonist effect of benzodiazepine. So that when you have overdose of benzodiazepine, you have to have flumazenil with you. It is used to manage severe benzodiazepine-induced respiratory depression electively. Next. Now, the route of administration of drugs needs to be understood. The safe administration of any drug requires a knowledge of its pharmacology, which is specifically related to the topic of pharmacokinetics and pharmacodynamics. While these subjects are potentially highly complicated and confusing to the non-expert, dental sedationist, and that is what Dr. Judith Mama is. She's a dental sedationist. She sedates her patients, and really in the United States it is well acceptable. But Dr. Mama, it's a big thing in the UK, and they are beginning to mandatorily say to patients that, or dentists, that you have to have an anesthetist to do this sedation. And now, dental sedationist needs to have a basic knowledge of sedation agent and the drug which may cause interaction with this agent. And whatever sedation agent you are using, you need to know the pharmacokinetics, the pharmacodynamics, and you need to know its absorption, the route by which it absorbs most, the drug interaction at different levels, right? And then the advantages and the disadvantages of this medication, the limitation, the side effect on the patient, and whatever complication. And one of the most important things that you need to do is to educate the patient on the fact that adverse reaction that you do not envisage may actually occur when you use medication. So that these are all the routes that we can use: inhalation, intravenous, oral, sublingual, intranasal, and I told you about that, intramuscular, and rectal. Now, the properties of an ideal sedative drug is that, it should be comfortable and its administration should be non-threatening. It should have a rapid onset of action. It must have predictable sedative and anxiolytic action. And that I find with Xanax. Controllable duration of action. And it must produce analgesia. And this is why a lot of dentists in those days were using diazepam and opioid. You see, diazepam and opioid in the hospital setting has never disappointed me. And in fact, because of the long waiting list for surgery, GA surgery, I had to start an IV sedation surgery clinic where I think on Mondays I do about 5 or 6 IV sedation at Cornwall Regional in those days, so that those patients are not taken to the main operating theater. Of course, there's a lot of politics there, because the anesthetists are not happy that you're doing it. You know, they believe that they have to be there. And this is in the hospital. So you see, there's no excuse for them to be upset, because I'm doing it in the hospital environment. So if there's any emergency, and it's actually ground floor, if there's any emergency, everybody comes in, rush, and help the patient, and help you. But still, it's like, hey, you know. It must have no side effect, and it must have a rapid and complete recovery. Benzodiazepine group of drugs has a number of desirable pharmacodynamic properties, and these include anxiolysis, sedation, muscle relaxation, and anterograde amnesia. Let us look at diazepam. It is not sufficient on its own, and that is true, for extremely anxious patients, hence the need to add opioid to enhance sedative effect. The most commonly used being the pentozocaine. Now, the above-mentioned technique with diazepam is just of historical interest, as midazolam alone can be used to achieve adequate sedation. And that is what is happening now. A lot of sedationists are beginning to use midazolam more and more. However, you have to use Hypnover, that is midazolam. You have to use it with caution, because it could be a funny medication. It could be a funny medication. I was a specialist maxillofacial surgeon at Cornwall Regional. We had a case in which we were going to reduce a nasal fracture for this young girl, 13-year-old girl. We did it, and you know, in the recovery area, the patient was being uncooperative. We finished the surgery, being uncooperative, and you know, and they gave her another dose of Hypnover. And when that patient was being transported to the ward for admission, because I guess the nurse realized that she was very peaceful, too peaceful. But on reaching the ward, they realized that she was almost gone. And she was like, she had to be on respiratory support for a few days. And when it was realized that really there's nothing that can be done, they had to let her go. All right? And the anesthetist made a mistake of giving her that second shot of midazolam. And some... Yeah, she died. Yeah, she died. The hospital had to make a decision that, you know, because if she brain damage, she will be a vegetable. There's no point. You see, the titration is very important. And midazolam, you know, some people, when you give them the initial dose, you know, it doesn't give the desired effect. And maybe the next dose will knock them off completely. So you really have to have an anesthetist. And that is why I'm stressing this to you. And this happened in an hospital environment, in the operating theater, where there is a consultant anesthetist. Actually, 2 anesthetists were around on that day. So that this really shouldn't have happened. Right? Now, It is twice as potent as diazepam on weight-for-weight basis. It is now available currently as 2 injectable preparations in 2 ml and 5 ml ampoules, each of which contain 10 milligrams of drugs. The advantages of using the 10 milligram in 5 ml preparation is that it is easier to administer by titration. That is, administering the drug slowly, in small volume, in increment, while assessing the patient's response. And again, it doesn't mean you have to use everything. It is absolutely impossible to predict the correct sedative dose of intravenous midazolam for any individual patient on the basis of their weight, height, body mass index, or the apparent degree of anxiety. It is only available in the UK in form suitable for parenteral administration. However, this formulation has been successfully mixed with other liquids such as fruit, juice, or for oral use. The 10 milligram in 2 ml formulation has been used in an intranasal spray. You see now? So you'll find, Doc, that would be very nice for you to introduce to your practice. And every time I say I'm going, let me tell you the reason why I have not bothered. I'm going to be very honest with you. You will notice my center, I have 2 kitchens there. Those kitchens, they're going to be transformed into an operating theater. And, you know, there are certain things that the anesthetists have told me to do. They visited. I have to knock off some walls and this and that and that. And I'm still contemplating what to do. And I have said to myself, I am not going to use IV medication unless I have an operating theater and I have all the equipment in place. Because it's just a matter of one little mistake and people will get you, especially if you have a lot of people looking after getting you. They'll get you. They won't understand that things happen. You know, things really happen. Even in big operating theaters and big centers. I mean, just a few months ago, the daughter of a professor of biochemistry in this country, she's working as a professor in North Carolina. And her daughter, her only daughter, first child, she's a Nigerian, was on admission in a hospital in Michigan. She's just 2-3 months away from her PhD, to get her PhD. They gave her the wrong blood for transfusion. And that was it. I'm sure it's a big, massive hospital and everything and so on and so forth. Things happen. You know? Let us look at temazepam. It is no longer considered to be the drug of choice as an oral alternative to intravenous or inhalation sedation in dental surgery. And in those days in the UK, 85, 86, you know, it was the main thing, especially for children, right? Because it comes as oral. It may have a place in the management of the apparent anxiety, i.e. overnight prescription prior to dental visit. And for the overnight prescription prior to dental procedure, I give diazepam. All right? I tell them to take it around 8 o'clock and go and sleep at 8 o'clock. And when they wake up, have something to eat, and then come to the office for 6 o'clock. And then I give them 1 milligram of Xanax, and they are snoring. So that is another modality. That is another modality. So temazepam is a minor metabolite of diazepam. which is impossible to solubilize and therefore not available in injectable form. So you cannot get temazepam in injectable form. You can get it in oral form. It has been produced in various forms like tablet, gel, capsules, and elixir. And this is what makes it very fascinating for administration. However, the capsule formulation has now been withdrawn because of drug addiction problem. And again, let me tell you this, Dentistry is very stressful. Very stressful profession. And a lot of dentists in the past, especially when these controlled drugs were not really controlled, have abused all these drugs. And, you know, my staff will say to me, but this Xanax, why do you order it per patient? I order Xanax per patient. I don't store it in my office. I mean, yesterday I checked, I realized we have a few tablets, right? But I don't store them in my office. I prescribe per patient because I don't want to abuse it. You understand me? I don't want my patient to abuse it. And of course, about 10 years ago, I had made an arrangement with Ministry of Health, with the Cornwall Regional Hospital, for me to store dangerous drug in my office. They had given me the prescribed cabinet. There's a prescribed cabinet. And, I got scared. After some time, I chickened out. And I bought that dangerous drug cabinet. It was very valuable to me. So I gave it to a medical doctor. I just chickened out of it. And the reason is, you think about yourself too. I'm telling you, I had wisdom teeth removed, about, say, 6 years ago in Trinidad. And the dentist is an oral surgeon. He has a nice operating theater. I mean, he did it under local and sedation for me. And he gave me Petidine, 75 milligrams. After, I liked the way I felt. I felt so good. And then, I'm telling you the truth. So I called him the following day. I said, Azad, I'm in pain, I'm in a lot of pain, You have to repeat the thing for me. So I went and I got it again. You understand what I'm saying to you? Because you want to feel good. So don't do it. Next. Now, the flumazenil. This is a specific benzodiazepine antagonist, and it has the same core structure as all other benzodiazepine, but has a strange affinity for receptor than most antagonists. As such, it will displace them. In other words, the receptors, it has more affinity for the receptors, so that it's going to displace. It's not going to allow the agonist to occupy the receptor sites. The anxiolytic, sedative, and respiratory depressant effect of midazolam is reversed by flumazenil. It does not reverse the anterograde amnesia induced by midazolam, i.e. the loss of memory or unpleasant event caused by midazolam before reversal is not reversed. With regards to sedation, initial assessment and treatment plan is important. You need to appreciate the symptoms of anxiety, and one of the symptoms of anxiety is sweat. And then, Patients who are anxious, they tend to repeatedly go to the restroom and so on and so forth, and they also miss their appointments. There's a way they sit, they're distracted, they have a distracted appearance, they sit forward in the dental chair, they hold handbag, tissue, they want to hold your staff, and so on and so forth, and not smiling, and all kind of things. And really, to be fair to our profession, it should be mandated that all of us be dental sedationists. Of course, with limited role, you know. Now, they also have dry mouth, need to visit the laboratory all the time. I mentioned that. They could faint, they're tired, and sweating. Next. Now, in your assessment of the patient prior to the surgery, you want to obtain a good medical history and do the necessary investigation. And of course, one of the most important investigation is CBC, complete blood count. And if that is all you have, you're good. But you can go further and do electrolyte and urea and a few other investigations. Now, you need to assess the patient's weight and the gait. And next. Now, the airway should be assessed for any abnormalities. Is there any breathing difficulty? Does the patient have cyanosis? Is the patient jaundice? Does the patient have anemia? And so on and so forth. Is the patient wearing prosthesis as a hearing aid? Next. Now, you need to obtain baseline records of the heart rate, the arterial blood pressure, and you need to connect the patient to a pulse oximeter immediately you are beginning to do your sedation. And another place where I enjoyed, and I still enjoy the facility, is at a very lovely hospital in San Fernando in Trinidad. There I do a lot of cases under IV sedation and using IV diazepam and petidine. Remember, it's an hospital environment, so I'm very cool with it. And, you know, I had a case of 4 wisdom teeth one afternoon. Of course, I wanted the patient to be put to sleep. And, you know, the anesthetist decided to cancel the case because he was busy otherwise. And so I just told the hospital, don't worry, I'm going to do it myself. Came and I did IV sedation. So that you really need to know how to do it, because sometimes it becomes very helpful. Now, having collected this information, you can now assess the operation and the need for sedation and the risk of sedation. And you actually scale this, and there are ways to scale it based on the American Society of Anesthesiologists. Next. And patients are usually classified as ASA 1 or 2. These are generally considered suitable for treatment in general practice or primary dental setting. Those falling in category 3 and 4 should be referred to specialist hospital center, such as teaching hospital and specialist sedation clinic for management. So this is the ASA fitness scale. 1, normal, healthy patient. Scale 2, patient with mild systemic disease. And scale 3, patient with severe systemic disease that is limiting but not incapacitating. So you can still sedate them. Patient with 4, a patient with incapacitating disease that is a threat to life. And then 5, patient not expected to have more than 24 hours to live. So really, if you don't expect them to live for more than 24 hours and you want to take a chance to do something that you feel that maybe it will improve the number of hours that they have, no problem. And in fact, these assessments are very, very important. Now, one of the staff in anatomy department, the father has a major medical problem, and they wouldn't take him to the operating theater because they assessed him that it was a risk. And in fact, when they finally took him to the operating theater, they had to abandon the procedure. They couldn't proceed further with anesthesia. Now, there are some social factors that needs to be considered. Now, you need to consider the time that the person works. You need to consider whether the person has children. And you need to consider also if the patient is breastfeeding, okay? Because a breastfeeding patient who has midazolam is bound to transfer some of the medication to the breastfed baby, and then journey to and from the practice. And of course, it is very important to have an extensive clinical and radiological examination. Treatment planning. This is the way you have to think. I'm going to treat my patient, do this implant, local anesthesia alone. I'm going to do it local anesthesia with inhalation sedation. I'm going to do it local anesthesia with intravenous sedation. I'm going to do it local anesthesia with oral sedation. Or I'm going to put the patient to sleep completely. Now, let me tell you where I stand. Where I stand is that I am very, very sensitive to a patient who wants to do implant and says to me, "Doc, I want to do the procedure. I don't want to feel or see anything. I want to be put in to sleep." Those patients, I do not argue with them. I give them what they want. Now, intranasal sedation using midazolam. Midazolam may also be administered intranasally as with oral administration. This application is currently unlicensed, and that is why you have not been hearing so much also about it. But maybe by now it is so. So you need to check. Now, you have dose of 10 milligrams and 10 milligrams per 2 ml concentration, which is usually sufficient and is surprisingly well tolerated by the patient. Rapid absorption into the circulation through the nasal mucosa occurs through this route, and it occurs sooner than the oral route. Of course, you have to monitor the patient in a similar manner as you monitor patients for IV midazolam. In conclusion, the simplest technique is usually the most appropriate technique. And my message to you today is that the simplest technique for me is Xanax. And it is also the cheapest. And you know, in fact, the most difficult patient I ever had, you know, when I gave him the 1 minute, I sank in 19 implants for him on my dental chair under local with sedation. And by the time I was doing the quadrant 3 implants, for some reason in the anterior region, he was having a lot of discomfort, you know, to the point that he almost boxed me. And what I did was I gave him another dose of 1 gram Xanax. And I tell you, he just slept. He slept uncontrollably. And when I was going to do his second stage, what I did was I gave him 2 milligrams of Xanax. And again, that 2 milligrams of Xanax sedated him appropriately, because remember, it's 19 implants. Of course, 2 failed, so 17 implants for second stage. You know. So, ladies and gentlemen, that brings us to the end of this lecture.